Welcome to DMEC Vitacaps, essential for DMEC transitioners. So we'll have the first talk by Dr. Bhaskar Srinivasan, Advantages of DMEC, why and how should I become a DMEC surgeon?
You would need to know what are the advantages. You are ideally replacing just the anatomical structure which is abnormal. You end up with faster visual rehabilitation. You end up with better visual recovery. The astigmatism is less. Rejection risk is less. Refractive change that you're inducing is less. All the benefits of a small incision surgery with respect to expulsive hemorrhage risk, globe dehiscence is less. If it fails or it rejects, the resurgery is simpler. So if you ask why DMEC, why not a PK, this eye, if you look at it and you see a significant scar, you see a significant vascularization, you see it's primarily an epithelial hypertrophy, you have endothelial changes also which is causing the decompensation, you have a scarring at the deep stromal level. Yes, you could have done a PK and got back vision, but that would have been a high risk graft with the induced astigmatism that a PK gives, with the risk of a globe dehiscence with trauma. And when you can get a result like this with a 6/6 partial vision with a DMEC, why would you want to do a PK? And you can see the significant improvement to the extent even the vascularization, which was primarily secondary to the stromal edema, significantly regress, improving the visual outcomes and reducing the risk of rejection. So the question should be not why DMEC, it should be why not in all cases that you see where you primarily have an endothelial decompensation and you can address whatever anterior scarring or epithelial hypertrophy is there with a bit of maneuver, either by removing the epithelium or by doing a PTK to remove the scar and improve the visual quality. So when you compare to PK, we've already mentioned what are the drawbacks of PK. Whereas when you compare it with the similar procedure in terms of a DSEC, which is also a small incision surgery, the anatomical replacement is with the stroma as far as DSEC is concerned, so that does induce a bit of a refractive change. The visual recovery is a little bit slower as compared to DMEC, even though there are reports which state that if you do ultra thin DSEC or a nano thin DSEC, the results are comparable to DMEC. But DMEC gives you a faster visual rehabilitation, and in terms of rejection, with both DSEC and DMEC, the rejections are almost similar. Indications are primarily for eyes with endothelial dysfunction, but if somebody is starting off endothelial keratoplasty, it is easier to start off with simpler cases. Fuchs would probably be the most ideal case, especially if it's already had a cataract surgery done and has a decompensation now. It's a lot easier because the Descemet's stripping is much more simpler. There is some amount of healthy cells in the periphery, so even if you end up traumatizing your tissue, the outcome is generally much better in Fuchs as compared to a pseudophakic bullous keratopathy, where it involves a significant damage to the entire endothelial cell population in that eye. How to become a DMEC surgeon would be to first read up about the procedure. You would want to see all surgical videos that are available, and now with YouTubes and conferences and online meetings, everything, you do have a backup of tissues in Facebook, various groups where you can look at various surgical procedures, surgical tips that are shared by the experts. It is better to actually meet a DMEC surgeon, sit one-on-one, have a conversation, understand the nuances of the procedure, attend wet labs wherever they are conducted, whether in your national conferences, international conferences, specialty conferences, see live surgeries as much as possible when it is done. You have the option of attending specific courses which they take with respect to DMEC. And once you have learnt about it, you have read about it, you have seen videos, and then you are ready to start, then your case selection is important. Select a simple case. Be ready with a bailout package in case you end up having a problem with DMEC. You should be comfortable doing DSEC. You don't want to do a PK in these eyes. If possible, get a mentor to be with you, especially in your first case. Initially, when you are doing it, you would need a backup tissue because you might damage the tissue while preparation or injection. So it's always a bailout in terms of having a backup tissue to do DSEC. Nowadays, with the availability of pre-stripped or preloaded tissues, that could also be an option. But again, there is a cost component to that. And even now in India, we probably just have the pre-stripped. We don't have the preloaded tissue, which is available in the West as such. In terms of before you start it, obviously practice, 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 because that's what's going to make it perfect. You don't want to be trying out a new stunt on the patient's eye. You want to be absolutely certain as to what you want to do. So when you're doing the preparation of the donor tissue, any of your DALC cases, you can actually strip the DM like you would do for a DMEC so that you get a feel of the tissue. If you are discarding any of these eyes because they're not being used for a particular reason, you can practice stripping the DMEC in those DMEC tissue in those eyes. You can try various techniques of preparing the tissue, and the idea would be to know various techniques, but you master one. So that is going to be your primary way of preparing it. But if there is a problem in that particular eye, in that step, you should be able to switch over to the next technique so that you are able to harvest the tissue without losing the tissue. Loading, again, you have the option of both glass injector, plastic injector, and you also have the option of loading into a cartridge like an Endoglide, or in terms of one of the ICL cartridges with a stopper, and you can do a pull-through technique like we do for a DSEC. In terms of simulation, you can have various options. So in terms of donor preparation, in terms of preparing the tissue in your practice, any of the discarded eyes can be used. You can mark the trephine with a 100 micron trephine peripherally, strip it and try to peel it off. And then once it's partly peeled, you make a 3 mm punch window which will allow you to mark the stromal side of the tissue. And then you take the central 8 mm or 7.5 mm punch. If there are ways of doing it where you can start peeling it off from the Schlem's trabecular meshwork and the Schlem's canal so that you get the DM in a complete peel. What is important when you're preparing the tissue is to keep it wet. The moment it dries, because of static friction, there will be a tear. You always have to look at the D when you fold the tissue, and if the D line is straight, you know that tension is equally distributed and it is not going to tear. If you feel it's kind of becoming like a V, then you know that at one point it is adherent, and trying to pull it up more in that area will lead to a tear. Always look at the edge and at the line where you are pulling it to be sure that you don't end up tearing the tissue. If you have a tear in the periphery, you can actually convert it like what we do in our Rexis, in terms of you can just make it the reverse cut so that it's like a crescent and it doesn't extend further. So it's important to notice this when you are pulling the tissue. The other way of practicing it would be in animal eyes, like a goat's eye or a porcine eye. You can actually remove the anterior capsule of the goat's eye in terms of the cataract. You can stain it with formalin so it kind of stiffens, and then you can use it because then the consistency becomes similar to what DMEC scroll is. You can do that even with the anterior capsule of cataract that you do a Rexis, but it's a smaller disc. It's only 6 mm, so it doesn't get you the complete scroll feel that an 8 mm tissue will give you. So with a porcine eye or with a goat eye, you can actually take a larger Rexis size, and that gives you the advantage of trying it out. The other option would be to peel onion and make a very thin strip of the peel of onion, which will again tend to scroll like a DMEC scroll, and you can use that as practice when you're practicing in the wet lab, trying to unfold it if you have issues with access to human tissue. One second. So the next step would be in terms of when you are preparing the tissue and before you load it into the injector, you need to be sure that you are marking it, because you need to be certain that you are inserting it in the correct orientation. So you have different ways of identifying it. One would be to put your F stamp or your P stamp on one side after creating a stromal window. Other option would be to just cut one edge of the DMEC tissue like an arrow, and you always know which side the arrow is going to point, whether it is going to point clockwards or anti-clockwise, so that you know that the orientation is correct. Generally, there is a tendency of the scroll to scroll with the endothelium out, so you can actually do the surgery even without marking. But in a cornea which is edematous, marking gives you the added precision required to be sure that you have not inverted the tissue inadvertently. When you're practicing injecting into the eye, obviously again you can do it in a whole globe in terms of discarded globes, or you can load it into an artificial anterior chamber. Now the only thing is an artificial anterior chamber has a depression in the center. So if you just try to inject the DMEC scroll and try to unfold it, it doesn't, it sits at the base. So it's nice to actually cover that with a gloves, preferably a white color gloves, which kind of gives you the contrast between the blue stained DM and the base. And that acts as the iris diaphragm, allowing you the access to flatten the chamber and allowing the tissue to unfold in the manner that you would want to. And this has been published by Dr. Rajesh Fogla. In terms of the goat's eyes or human eyes, it's similar. You can remove the lens and inject it and unfold the tissue using various techniques which have already been popularized. Loading the tissue, you can load it from the smaller part of the pipette, you can load it from the back side of the pipette, you can load it, you can fold it and load it with the endothelium in. Try all the types of loading that you can do. Always, if there are 10 ways of doing it, do it all the 10 times. See which you are most comfortable with, and then just keep doing that one test one way so that you perfect that before you go on to the next way of doing it. But you should be aware of all different ways of skinning the cat. Last would be to inject the tissue. Once you have loaded it, it's important to see the orientation of the tissue. So it goes in a double scroll or a single scroll. It's like a dosa, it folds. So you need to see the angle that is created. So the triangle with a base down indicates that it is going in the correct orientation. So near the pipette tip, it has to be a base out. Near your side, it has to be a base out. That tells you that you are in the correct orientation. You inject the tissue without too much of force so that it goes in that correct orientation, and then you are able to open it. So this is just a video showing the opening up in terms of how you would want to open up the tissue. So you can then pin it on one side and tap either on it like a carpet rolling method, or tap peripherally to unfold the tissue. And once the tissue is unfolded, you can inject it. So this video by Vikas Mittal just kind of tells you the maneuver that you need to do once the tissue is inside. So to conclude, if you are starting on your procedure, read literature, attend labs, meet with mentors, practice, identify the ideal patient, and that will help you conquer the surgery. Thank you.
Thank you very much for those insights, Dr. Bhaskar. Any questions from the audience? I will go to the next topic by Dr. Anita Venugopal, Chief of Cornea at Arvind Eye Hospital, Tirunelveli. Her topic is Keys to Success, Right Donor, Right Patient, and Right Resources. Can we have Dr. Anita's presentation?
Hi. It's already there here. Good afternoon to one and all. Thank you, Seema, and I would like to thank the AOS organizing committee for having me here. My talk is on DMEC, the key to success, the right donor, patient, and resources. So we are all aware that PK has been a standard treatment of choice for all corneal diseases for about a century. After ZIM has started in first keratoplasty in 1905, and the lamellar procedures have come up in past 2 decades by leaps and bounds, and the DMEC has scored over DSEC. because of its good visual outcomes and lesser rejection rates. So the first key to success in DMAC surgery is right donor, selection of the right donor. So the older tissue, the thicker the graft. So the thicker graft is leads to the unscrolling becomes easier. So what makes the graft thicker with age? It's because of the deposition of the posterior non-banded layer, which makes the graft thicker with age. So this helps in easy unscrolling technique in anterior chamber. So during your initial period, you choose donor of age more than 50 or 60 years. And as time goes on, and if you get better, then you can you can include younger donors later. So, and even now, like most of the skilled surgeons, they do with less than 50 years donor age, and include donor age with donor tissues with endothelial count of more than 2,500 per millimeter cube. That is because, so whenever you are tapping each time, the like imagine that you are going to kill all the endothelial cells. So, and whenever it comes in contact with the IOL or the other intraocular structures, iris, so you're going to kill the endothelial cells. So it is better that you have a good endothelial count from a good phakic and with good morphology eye. So next would be choosing a right patient. So as the Bhaskar sir has mentioned earlier, the ideal choice for a beginner is Fuchs endothelial dystrophy and a pseudophakic bullous keratopathy, and with a good visibility and intact iris and round pupil. And confident surgeon can perform in endothelial failure in post-PK, angle closure, and glaucoma drainage devices and trauma. And it needs little more skill in performing DMEC in iridoendothelial syndrome than doing a DSEC. And these are not right patients, like at least in the beginning. So avoid doing in post-vitrectomized decompensated eyes, a phakic bullous keratopathy, patient who cannot lie down supine and with high risk of bleeding. Avoid deep anterior chambers, aphakic eyes, and post-filtering surgeries. So what are the right instruments? So choose your instruments which is good in your hands, that's all. So the rate limiting steps in DMEC could be separation of the DM from the donor, and then peeling of the DM, and the injection of the graft. So these are the rate limiting steps. So the instruments can be divided into donor and recipient related. The donor related instruments would be trifines. You require 3 trifines for this procedure, and DM elevators or graspers or strippers, and instruments for marking, and insertion tubes, cannulas, glides, or cartridges. So right sizing of the donor. Before doing a right sizing, you measure the white to white of the patient's cornea. So that will give you right choice of the punch to choose. And most of the surgeons, the senior surgeons would prefer doing first 9.5 mm triffination for the initial large diameter triffination, but I prefer doing 10 mm trifine, like a partial thickness with a guarded trifine with a punch lock. And next step would be using 3 mm trifines, which is a skin punch biopsy trifine, to create a stromal window for marking the anterior surface of the strip DM for orientation. The last trifine which we use for DMAC would be 8 or 9 mm, which depends upon the patient's cornea. That is the final graft size. So most of the surgeons prefer Hesbank Barrett style trifine for this. So next would be the critical step in DMAC would be separation of the DM from the periphery. So it becomes easier, like if you choose your own right instrument which is comfortable in your hands. I use a femto spatula, the opposite side of the femto spatula, which looks like a Sinskey hoop, little longer than the Sinskey hoop, that goes and it helps me to create a liftable edge there. So from between the DM and the stroma, so I create a liftable edge all around the 360 degree of the cornea with this femto spatula itself. And then next step would be peeling of the DM. So this we have so many instruments available in the market, and this instrument particularly I want to mention, the name is Foglas hook. So this has actually a large surface area compared to our normal capsule forceps. So and the curvature of the hook is also like in direction of the DM, so you can catch hold and steadily, and it is basically customized to peel the DM from the stroma after the separation. So I use basically this capsule forceps alone. The whatever may be the instrument, here the right technique is important. Like the peeling of the DM should be in an acute angle, and you have to make sure that the edges are not turned during the peeling of the DM, and make sure that the D sign is correct, that the horizontal sign is there. Next would be the marking of the DM. Marking of the anterior stromal part of the DM. Sorry. So any asymmetric mark can be used, F, P or S. So the trick here is dry the stromal part of the DM as much as possible, because that smudging of the dye may cause you will not that will the orientation of the graft might you will find it difficult after inserting into the anterior chamber. So to avoid that, dry the area as much as possible. Next would be the recipient related instrument, the DM Revasinsky hook. That is same as that of the DSEC and the injector systems. So injector systems are either made of plastic or glass. So glass is said that it is least traumatizing to the endothelium. So that is more preferable compared to the plastic. So there are various instruments like ICL cartridges, IOL cartridges, Endoject as plastic injector system, modified Jones tube, bent pipette, and Gouda cannulas for the injections. I use this BD syringe and a cut IV cannula, rubber tube, and then this cartridge. So the wing of the cartridge is broken, and I just keep this injector part of the cartridge alone. So this I prepare for before each surgery. So it takes just few minutes, and this would be prepared. Like there is no problem with the sterilization also if it is done just before the procedure. So all the parts are assembled, and it has been like quite easy. Like the stability is there with this instrument for me, and I prefer to do this in this way. So crucial steps in DMEC compared to that of the DSEC. The recipient preparation, the DM Rex should be made 0.5 mm more than that of the donor graft size, and you have to ensure complete removal of the DM remnants in this DMEC compared to DSEC, because to avoid post-operative graft detachments, and inferior PI is a must, and avoid a fibrin formation that also in post-operative period can pull the DM into the anterior chamber, so that will lead to a graft detachment. In donor preparation and the loading and the transferring, all this, it's little difficult, but can be mastered with the wet black practice, as Bhaskar sir has said already. And DM graft unfolding, it's the most difficult thing, because each tissue it behaves differently. So it definitely requires some practice. An air injection, that has to be very careful. It has to be slow and steady when you inject the air, because it may lead to decentration intraoperatively. So immediate post-op care, that is also important. So key to success is choosing an older tissue at the beginning of the surgery, like for a beginner. Size it right, stain it, and create a liftable edge. Submerge and strip, punch and stain, inject the donor, stitch the wound, adjust the orientation, unfold and position. Thank you.
Thank you very much, Dr. Anita. Any questions from the audience regarding right resources? So, Dr. Anita, any suggestion from you as to one specific instrument if you think you should have in your DMEC kitty? Any suggestions?
Like the injector system, like you teach all the your assisting sister how, like whatever the injector system you want it. So you train them first so that all the DMEC set, everything, whatever instruments you are using for DMEC, you just keep it separately. Don't use it and mix it with the cataract surgery, because that also will, the instruments can get worn out.
Fair point.
One more point. Basically, the glass injector gives you a very good idea about the orientation of the tissue before you are injecting it. So even though it is a little bit expensive, it's worth the money. Second is, when you're injecting air and saline, you have to maintain separate cannulas and syringes for air and saline. Do not mix and match. That's the most important thing that you will need to tell your sister, to keep separate syringes. Invariably, when you want a single bubble, you'll get a fish egg, and vice versa. So, and that can significantly make a good surgery, which was going on perfectly till that time, go haywire, because the DMEC tissue would have got pushed to one side, and then you're searching where the DMEC tissue is.
Couldn't agree more. Yes, and glass syringe would be my go-to also. Coming to DMEC graft journey, donor to injector. Now we already have the basics of DMEC, right? Preparing the DMEC graft, it's not so difficult. It's just that you need the right tools, and you should have your own technique. There have been various techniques published: scuba technique, pneumatic dissection, liquid bubble, and yogurt technique. But the conventional stripping technique still holds good and is the gold standard. Is the technique that I still follow. Published right from 2008. Then you had all the various other publications followed by that. A review of the evidence for in vivo corneal endothelial regeneration tells us that the corneal endothelial cell density is higher in the periphery. And in a DMEC graft, you want maximum endothelial cells. You want as much population of endothelial cells as possible inside your graft. What could you do then? Make your graft a little peripheral. Instead of making it right in the center, skew it little to the periphery. It helps you to take more endothelial cells inside your graft, so that your DMEC dance, how much ever you dance inside the anterior chamber, you still have enough cells to hold the graft in good stead. Eccentric graft peel enhances cell density in graft, and possible peripheral putative stem cells are also there in the periphery, which will also help the graft to fare well. The graft preparation trolley is very important. These are the various instruments you require to have in your trolley. As Dr. Anita already highlighted, the two syringes I've shown here are BD syringes. They are the white piston syringes. They don't have the rubber cork. It's very important because they are looser to inject and aspirate. You don't want a very tight suction which suddenly gives way and you have to, kind of grasp you suck the graft inside and damage it. My other go-to is the Guder cannula. Because of the transparency, you can't see it well. The Guder glass cannula, or probably even a Jones tube, would be my go-to for injection. A Petri dish with saline. Basically, apart from the injector, all the instruments are your regular OT instruments. There is nothing. Even the injector, like Dr. Anita said, you can have the do it yourself injector. The important thing is, when you're having the Teflon block that you usually use, it has a hole in the center. The Teflon block that you use for PK, for punching, has a hole in the center. It is important to block that hole from the base so that the liquid doesn't flow out. In PK, while punching, you don't need fluid. But in DMEC, while punching, you want, when you're actually peeling the graft, you want fluid to be there. It should not escape through the hole. Then there are two kinds of, it's not going to the next slide. Excuse me. Yeah, so your tools, like I said, the BD syringe, there are two types of spears that I use. One is the PVA spear, the blue one, and the other is the cellulose sponge. The green cellulose sponge is a fast soaking sponge. The PVA spear is a slow soaking sponge. So when you have more fluid and just want to remove all the fluid quickly, you can use the green one. But the blue one you will use when you want the fluid to drain out very slowly in the presence of the graft in your field. This is the DIY injector sensor cartridge, the butterfly cartridge, which Dr. Anita already spoke about, along with the BD syringe. Okay, you need just a piece of IV tubing in between to make this. Now we come to the steps of graft preparation. First peel, staining, making a stromal window, marking the graft, second peel, and staining and loading your graft. These are the steps. So coming to the video of the first peel. So like she said, a 9.5 mm usually is the first refine that you use. The first refine size is determined by the graft, the donor. The second refine size is determined by the host corneal diameter.
So remember, 9.5, once you have created a partial thickness, light tapping movements, this is the fast soaking spear. Then you create that 360 degree liftable. Now this is 360 degree. Here there is no hinge. All around you have to make a groove, and the peripheral DM has to be stripped out completely. No remnant or tag of the peripheral DM has to be there. Once you're sure that you have created a 360 degree liftable kind of groove, that could be done either with a Sinskey hook, it could be done with a femto hook spatula like she mentioned, it could be done even with a phaco chopper, a phaco chopper with a sharper edge. Once you have created that, only then attempt to lift your graft. Without doing that, if you try to attempt, you will be wasting your graft by creating unnecessary tears. So here I'm trying to lift my graft. This is a single one hand technique. My left hand is not having any forceps. Earlier it had a forceps, now it has nothing, only my right hand, and I'm peeling slowly. Look at the descent, that is the horizontal mark. Look at both sides, both ends. There should be no tear as you are slowly stripping. Once you have, here you have to retain a hinge. Here you don't peel completely. Once you have the hinge, you are punching the residual stroma. Now the DM is on one side. The DM is at the bottom. This side is where only the stroma is there, and you're punching with a 3 mm punch. You're drying. Now the graft, you're laying it back. So the punch is being made only in the stroma, not in the Descemet's membrane. You float it with saline, and without touching the graft, you can just absorb the fluid with your spear, and it lays down flat on its own. You don't have to touch the graft at all. So 1 point of touch is what you would like to maintain. Now, marking the graft, there are methods where you don't have to mark the graft, but take my word for it, in Indian eyes with dark iris, you do want to mark your graft. Especially our cases are dense stromal edema, you do definitely want to mark your graft. So you lift that window from the opposite side. Now you go to flip the graft, go to the epithelial side, lift that stromal window and dry both sides. Dry the endothelium Descemet's membrane and then put your F mark on it. Don't allow the F mark to smudge. Then you put the window on it and close it. Next you can flip your graft, bringing it back to the endothelial side. Now we go to the second peel. Here, like I told you, this will be determined. So if your donor is 11 mm, shortest diameter is 11 mm, then I would go for an 8 mm graft. So roughly about 3 mm downsizing. Again, light taps should do it. You want only a partial thickness definition. Stain with Treban blue once again. Make sure you're seeing everything clearly. Now outside your 8 mm punch, you're peeling the rest. Now this 8 mm is your final graft. So you remove the Descemet's membrane outside it. Once you peeled outside the 8 mm, what is left is your DMEG graft. So you are going to hold that DMEG graft also only with one touch. Lift it and laid it back and stain it this time for 1 whole minute. With Trepan blue for 1 whole minute. After staining for 1 minute, take the blue sponges now. The blue sponges are slow soaking and 2 blue sponges are important. If you take one, it will move over to one side. It will go and stick to the sponge. So you want to dry it from both sides. Once you're done with that, your graft is now ready to be loaded into the injector. Preparing the injector system, since I use a Guido cannula, this is the way you prepare the system. It's easier with a glass cannula because it has one broad end and one narrow end. The broad side is for loading, the narrow side is for injection. Make sure your entire tubing is free of any air bubbles, that is full of saline. And then you load your graft into it, connect the other end with a BD syringe and then disconnect the central tubing so that the whole system is in saline. So this is how you prepare your injector system. Now loading the graft, you put it in the petri dish which has saline, and with the broad end of the injector, just aspirate it. The BD syringe allows very controlled aspiration. There you have your perfect Goldilocks double scroll. Keep it submerged in the water, the saline, and then remove the other side. So check the F mark and orientation within the glass cannula before you inject. That will save you a lot of trouble of identifying the side once you have injected the graft. If your graft is looking like this, with so much of staining, which means the endothelial cells in those areas are not functioning. Please discard that graft, don't use it for a DMEC. Issues with peeling, you may have a hard peel where you are struggling, like earlier was mentioned. If you are having difficulty and you are seeing so much of taut DM, you are going to face troubles. If you're sensing that there is one area which is tighter than the other, you want to skew your peel to the easier side. You don't want to keep pulling from the harder side. Now if you see, I sense that there is a problem on one side. Now I'm skewing the peel from the left side. I'm not peeling so much from the right and still maintaining the hinge. If you have a graft tear, again, you're pulling it from one side. You see, if you sense a tear, go back and stain it and check if there is actually a tear. There is a radial tear. Convert it into a rhexis, like it's called the Nike sign. You make it like a Nike, the trademark of Nike, and go to another area and complete your peel. Make sure you don't remove the hinge. Keep the hinge in place. Okay, so that's how you would manage a graft tear. Again, as far as marking is concerned, you don't want saline fluid there. So if there is a fold in the Descemet's membrane when you're marking, invert the graft, release the fold, stretch the DM back into place. You'll have to recap this graft, refloat the graft, stretch it nicely so that it's a very taut sheet. Then you can flip it back and mark it. But if you're doing second time, I would advise do it with a Sinskey hook so that you know exactly where your mark is going. Don't do it with the F because it blocks your view. So don't do it like that. Then you cap it back and you're done. Do not compromise on the mark though. Redo it if you have to, but do it. Second peel usually does not have any issues. Sometimes you may have the DM which is not completely torn in the second trephination. So if that is the case, you can use a Vanna scissor to cut the second peel. That is the final graft. So once your graft is ready, you're all set to inject it. Injector tips, like I said, choose from IOL or different glass syringes. Check the graft orientation within the injector and use a plastic plunger, a white plunger like a BD system for aspirating and injecting. If you're having graft preparation failure, it's mostly because of extension of the peripheral tear into the central area. Don't allow it to extend to the center. Complete the excision without a hinge will cause a problem. Always maintain your hinge. And if you have tightly adhered tissue or brittle DM, identify it earlier and do the needful. Conclusion is stripping technique is highly recommended, especially with beginners. Cell wastage is minimal, so you don't have to depend on the eye bank. You can always strip your tissue on your own. Overall, endothelial cell loss is only 4 to 5% in the hands of the surgeon. It's simple instrumentation, and your dependency on eye bank for pre-stripped tissue can be minimized. But beginners should always have a backup tissue. So these are the various types of scrolls. And now we go to the DMEC dance. Dr. Bhaskar, all over to you.
Excuse me, the turn up. So we look at how to unscroll the graft. नहीं आ रहा भैया? हाँ, okay. लिया? ये तो अच्छा है। लाइट की वजह से लाइट बंद कर सकते हैं, बट पहले वाले तो अच्छा आ रहा था। क्या? दूसरे वाले में लगा दो। पहला वाले टॉप में तो अच्छा है, बहुत और
अरे कॉपी कर लिए होते पेन ड्राइव में है इसमें।
एक मिनट, वीडियोस है, एक मिनट। सॉरी, है इसमें नहीं, इसमें नहीं। बीच में चल रहा है, बीच में बंद हो रहा है, पता नहीं क्या। इसमें भी हाँ, एक मिनट। हाँ, ठीक है, एक स्पीकर नहीं है तो उतना प्रॉब्लम नहीं। हाँ, ओके, 1 सेकेंड। I think you can.
छोड़ दो तुम।
नहीं, ये वाला है, नीचे नीचे।
कर रहा है, मैं आपको दिखा
हाँ।
रहा हूँ आप कर।
So basically, when we are looking at unscrolling, just to repeat the points, you need to have your orientation of the tissue correctly. The orientation itself is okay, fine. Okay. So basically, once you are injecting your tissue, these are the steps which you've already discussed in DMEC. So before you're injecting your tissue, you need to make sure that your visibility is good. So in an eye with a significant edema, you might want to debride the epithelium. You can put glycerin to improve your visibility. And in eyes with scar, you might actually even consider doing a PTK to remove the anterior haze a little bit so that your visibility improves. When you're loading the tissue, like was shown in the previous talk, you need to make sure that you load it in the correct orientation. You have the option of flushing the tissue back and forth in the injector from the narrow part to the broader part of the tissue, as has been described by Dr. Fogla, which allows the tissue to go back into a double scroll or a Goldilocks configuration. Once it's in the Goldilocks configuration and your chamber is a bit shallow, then it's a lot easier to unfold the tissue. So here, before that technique was described, we could just agitate it on the bed itself to get the thing. You can see the nice F mark, you can see the double scroll orientation, and when you are injecting the tissue, you need to be sure that it goes in smoothly without a jerky movement. The AC maintainer is stopped, and before you start the injection, it is disconnected from the IV so that the fluid will go into the AC maintainer and the tissue will not come out along with it. Once it is inserted, then you tap it, hold it on one side and tap it on the surface like a carpet rolling. Once one side is free, you can just roll it out, and then once it is unfurled, you put in an air bubble to kind of fixate the tissue. So it's important to look at the orientation. It's important to see a free edge. It's important to then pin that edge and then tap it. You can tap either in the periphery, or if it's a tight scroll, you might want to tap on the center to kind of roll it like a carpet. So this is the video which is basically showing you the agitation to kind of achieve a double scroll. So it takes a little bit of practice because you sometimes flush it completely out of the system. So you need to understand how much force you need to use. You need to get it just between the funnel to the broader part of your cannula and back. And once you get the Goldilocks scroll here, it's actually gone in very fast. It has taken a little bit of time for it to kind of spin inside, so which should not happen, because if it goes in very fast and it spins, then all the effort that you took in to achieve the scroll becomes negated, because then it goes inside, it becomes a tight scroll, you're again fighting a battle and unfolding the tissue in a longer period of time. So here, in fact, this patient had a very dense haze. We did a PTK to reduce the spheroidal, and in these eyes, it's important to stain the tissue more densely, because your visibility is compromised. You want that blue stained tissue to be seen more easily. Here, it is absolutely imperative to get a double scroll. So you might want to use a tissue which is somewhere around 60, not a very older tissue, as well not as a very younger tissue, because older tissues sometimes, because they are so flat, don't get into a double scroll configuration. A younger tissue goes more into a single scroll configuration, and it becomes difficult to unfold. So again, the process is very simple. You get the scroll, you put it in the eye, allow one side to open up, you pin it. You can either depress the anterior chamber on one side, or you can let a fluid loose so that it kind of unfolds. If it goes as a taco, or it goes as this thing, you can just deepen the chamber so that it allows it to come in the correct orientation, and then you can redo the entire process. But the most important thing is if it goes in smoothly, if it goes in without a jerk, if it goes in either in a double scroll or a single scroll configuration, but in the same manner, you can just tap on the surface, it opens up partly. Once it opens up partly, pin one side, tap on the periphery, it opens up. Keep the pin in the center, tap in the periphery, it opens up. You then shift the tissue so that the orientation is correct. You need a little bit of fluid for all these maneuvers. At the same time, you don't need too much of fluid, which will prevent your graft from unfolding, and it will keep getting into a scroll formulation. So here we are loaded the tissue in a double scroll form, and once we are injecting inside, it's gone in pretty fast. It shouldn't, but the scroll orientation is maintained. So once the orientation is maintained, we are just centering the tissue. Now once it's centered, we can pin it on one side, tap in the periphery to allow it to kind of open. Since its tissue is moving, you again kind of tease the tissue because you need space for it to unfold. If it gets too much to the periphery, it's not going to open. That part, the chamber is shallow, so there's less space for it to unfold. So you want to get it close to the center again, and then tap it in the periphery so that it unfolds. It's just the fluid movement back and forth. So you need to understand the minimal amount of manipulation that you need to do to achieve the unscrolling. At the same time, you don't want the tissue to get stuck on one side or come out through the incision. So it's imperative to actually suture your incisions, at least for the first few cases, to be sure that your maneuver doesn't push the tissue outside your main port. This is again a patient where we are just injecting the tissue. The other important thing here is when you are injecting, we have seen your tissue orientation in the funnel. Before injecting, you always see how the opening is. So you're going in with the bevel down, you're rotating it either temporally or nasally, so that when you are injecting it, it goes in with your scroll. So you identify where the scroll is with respect to the opening of your goiter cannula, so that you can adjust it once it is inside. You wouldn't want to go in, say if it's inversed also, you wouldn't want to go in with the bevel up, because sometimes with the bevel up, you might not have entered into the anterior chamber completely. It might still be in the lip of your tunnel, in which case the tissue will not go in. So go in with the bevel down, so you're sure you've gone across the incision. Then you rotate it, so you're sure you're in the anterior chamber. Then you inject it, and when you're coming out, make sure that you come out slowly. You can have your second instrument at the incision so that there is no leakage of the tissue through the incision. And at the same time, before you are injecting, you are decompressing the anterior chamber. If you have not used an artificial chamber or AC maintainer, if you're using an AC maintainer, disconnect the AC maintainer so the fluid goes into the negative suction of the AC maintainer and allows space for the fluid to go into the anterior chamber. So here we have injected the tissue. It has gone in with a little bit fast. Luckily, the orientation is maintained. We're just tapping on the surface, tapping on the periphery, and that's done. So if you inject it properly, within 30 seconds to a minute, your unfolding is over, your tissue manipulation is reduced, and you get the best result with respect to less endothelial cell loss. This was a glaucoma patient with PCAG with DMEC. We did the cataract surgery. We're injecting the tissue. So it's gone in nicely with a double scroll, but there was a time lag between the removal of the AC maintainer, so there was a flip of the tissue. So if you have to flip the tissue, go in, gently inject, so you can see the tissue flip. Once it is flipped, then you can pin it and open it on the other side, again center it. So when you are spinning the tissue, it's just a small jet of fluid into the anterior chamber, which just slightly deepens the chamber and the tissue can flip. If your chamber deepens too much, what happens is the tissue gets pushed to one side and it will almost start coming out through the anterior chamber. So you don't, unlike in a cataract section where you want the chamber to be deep and formed, here if there's a little bit of leak from the side port also, it's not bad because it just gives you the fluid wave without increasing the pressure inside the eye. If the pressure in the eye increases, the chamber becomes deep, the tissue can kind of become more tight, or the tissue can get pushed to one of the incision sites and then it causes more damage. So this was another patient where again it's important to size your graft. So if your white to white is lesser and you have a larger graft, sometimes when you are injecting, the graft is almost at the edge of your incision. So there you don't have a choice, you might have to probably hold it and push it inside. So it's important to size your graft before, so it's good to actually, sometimes we prepare the tissue and then go to the patient, but if you do that, you might have this issue. So you always make sure that you measure the patient's corneal diameter before you prepare your tissue. Because if it's a larger tissue, it kind of gets stuck at the incision, and whenever you're trying to insert your cannula to inject air also, it might sometimes go above the tissue rather than going under the tissue. So when you're looking at the insertion, you have this Walterman's technique where there's given various scrolls how you would want to unfurl each, but the basic principles are the same. You try to get a double scroll, you pin one side, tap either in the center or in the periphery. If you have origami, inject saline to get it into a scroll formation. If that doesn't happen, you just have to give a flip of tissue, deepen the chamber, it will come into that configuration. If it forms like a taco, that's the most challenging part because you need somewhere space to pin the tissue down. So you can then again deepen the tissue, allowing it a tendency to go into a single scroll and then try to open it. An older tissue, when it is very flat, sometimes you might feel it is easy to unfurl. It is easy if it goes in the correct direction. If it doesn't go and it becomes a taco, then it is difficult to get it into a curling formation. You might just need to get one edge. If you can get one edge, you can pin that and open it. Otherwise, you might just have to hold it with a 25 gauge or a 23 gauge forceps and unfurl the other one. If it's a deep chamber like in a post-vitrectomized eye kind of a thing, you might want to depress the anterior chamber a lot more to kind of achieve it. You might want to, when you're pressing the tissue down, you might still have to egress fluid from one of the side port to make sure that the chamber collapses for the tissue to get flattened out. Or you might want to use a little bit of pressure on the mid-periphery in the equator to kind of shallow the chamber because of a pressure on the equator. Or you can use an air bubble in the front to kind of open the tissue from the front. But those are challenging situations, especially if it's if you're doing an SFIOL in a completely vitrectomized eye, the pressure doesn't build up. So those are issues which are going to be a little bit of a challenge. And you might want to take a slightly older tissue, somewhere around 60, so that your unfolding becomes a lot easier. Or you might want to consider a pull-through technique where you have control over the tissue, where you're holding it and allowing it to unfold. Thank you.
Thank you, Dr. Bhaskar, for those wonderful points. Just 2 points that I would like to mention is, one is while injecting, avoid a snug fit of the injector. Make the injector, know the size of your injector and make the incision accordingly. Never try a wound assisted, it never works for DMAC. You have to go inside well into the anterior chamber and then only inject. And the other thing is when you have the double scroll, which is wider at one end and narrow at the other, tap the wider end. That will help the scroll to unfold very easily.
And when you're doing that, when you're injecting, you can inject it slightly on the left or on the right based on which side is wider. Because you know it's going to be able to, it's easier for you to open it up on one side. So you have the smaller side on one side and the wider side on the other. So it is unlikely to flip the other way down. So if it is wide on the right, I would place my tissue slightly on the left in the cornea. I place it, I tap it on the right side, so part of it is opened up. If you do it reverse, then it will kind of flip around when you're trying to decompress the eye.
Sir, I have a question. Like after the air injection, if you find that the graft is decentered, so what we have to do next?
So you will have to aspirate the air again, inject a bit of saline. Sometimes it might still get stuck so well that it might not move. You might have to hold it a little bit and pull it down because you have to detach it from the cornea. You will have to press on the external surface, detach it from the cornea so it goes into the anterior chamber again. It will form a scroll and again you start your thumb on the plunger, take your cannula to the center of your pupil, then inject. Because even that little bit of touch on the plunger can kind of release an air bubble before you want it to, which will displace the tissue. Okay, hold it like a pen, go to the center, and then gently give a small bubble. That is why it's important to have a fresh syringe which has not been used for any fluid, so you get a single bubble. Once you get that small size bubble and the tissue is in the correct position, then it becomes easier. If it goes in with a jerk, sometimes even if the tissue is, even if it's a single bubble, it tends to kind of displace the tissue because of the little bit of fluid. What you have kept as a centered tissue kind of shifts a little bit. And then you feel, do you want to do it all that process again just for that minimal shift? And you sometimes tend to leave it, and then that comes back to hurt you because that peripheral area tends to have microcystic edema, which takes longer for it to settle in the postoperative period.
So next we have talk by Seema on DMEC in complicated situations.
Laptop. Where is my folder? Excuse me. Yeah, I got it. So DMEC in challenging situations. Are you seeing the slides, please? Slides on the screen, please. Thank you very much. To answer Dr. Anita's questions in one of my videos. So this is about challenging situations. You will always face challenging situations when you start doing DMEC. So what are the main reasons for it? Poor visibility and poor contrast. Visibility is poor most of our cases because more than Fuchs we have PBK eyes and they have dense stromal edema. Contrast is poor because we have dark irises. So even the bluest of blues also doesn't give you that contrast, you'll see later. Phaco with DMEC or a combined cataract with DMEC kind of situation, you have to do phaco under poor visibility and then start doing your DMEC. Presence of vitreous or fibrin in the anterior chamber to be identified. Vitreous, I would say, still is okay, but if you have fibrin, then it's a worst case scenario. Previously vitrectomized eyes or eyes with ACIOL or SFIOL, these are challenging situations. Large or irregular pupil or iris defects, you need to address those issues before you complete your DMEC. So we'll see a few of these situations now. This is one of my, simple, we saw in Dr. Bhaskar's videos about the endo-illuminator probe that he was using to highlight. So you have a simple endo-illuminator source for DMEC. So this is how you would want your life to be. You know, the kind of contrast that you're seeing, these are all Western eyes. These are all published in literature, they're all Western eyes. You would like to see your graph so nicely. But what you actually see is this, and this. Where is the graft? I can't even see it because the visibility, because of our corneas being so edematous and the iris being so brown. So the problems with visualization in DMEC, the pathological corneas, PBK eyes have poorer visibility than Fuchs eyes, and graft staining fades over time. So the more time you take to open your graft, the more staining is fading all over time. And if the F and S stamp is not visualized well through the hazy cornea, then it would be difficult. So endo-illuminator assisted DMEC has been reported in literature, but what is this endo-illuminator? This is what our VR colleagues use. We have to depend on our VR colleagues. You either have a VR setup or you have a VR spouse. You decide what you want. I have a spouse. 50 lakhs to 1 crore is your investment for the VR setup. You don't really have to go for that. If you want independence, you can have a separate standalone light source. This is also 1.25 lakhs INR. You need a fiber optic probe, which you may borrow from your VR colleague. If they have discarded one, you can always ETO it and use it. It still works. I've been using the same one for the last 2 years with ETOing. It works well. But again, you want something cheaper, very cost effective. You can use an LED torch or your mobile flashlight also. Okay, the point being, you just need that fiber optic light source, which your VR colleague can give you. And then you have the mobile, this is how one of my assistants is sterile, the other assistant is unsterile. She is holding my mobile, flashlight on, and that the VR probe, she's holding it to the back end, the light of the mobile flashlight on the back side of it, and I'm holding the sterile end of the endo-illuminator, the probe, the light probe. We switch off the room lights. She holds it, because this mobile flashlight is very small, you can cover it nicely so that all the illumination is going through the fiber optic probe only. So this is how you can see, this is how without the light probe, and there, if this could be off, that would be great. ये light off हो सकता है भैया?
ये वाला light? Okay. So actually, I am not sure if with this light you can see it, but here is the F mark, which is ulta. Okay, this is an inverted graph, which here I am not able to see at all, but there I am able to see. Here again, this is again comparison. Here I am not able to see at all, but here I have the F. Sorry about this illumination, but I am not saying it will work as well as your VR light, because VR light is very bright. This is the comparison. LED, we did a luxometer also. LED torch gives you 695 lux, mobile light gives you 307 lux. VR or your standalone, the one which I showed you earlier, it's 238 into 100 lux. So 238 into 100 lux. Okay, that is your illumination. Obviously, that is going to be much better. But this, most of the time, your mobile light is sufficient. You can use it and works well. So this is a case where I used it in a case of failed PK. Despite removing all the epithelium, the failed graft, we know it's an endothelial failure. So a DMEC is okay for this kind of a case. I've injected the graft inside, but it's gone to one end. Like it shot and it went far in the angle. But whether it's in the angle or in the AC, I'm not able to make out at all. So despite trying to tap and center, I could not see the graft, and I started using. This is the mobile light that I'm using. And I'm looking for the graft, but it's nowhere to be seen. Though I'm sure it went in well, I saw it go well into the anterior chamber, but I couldn't. Then I found it, edited the video. I found it, tapped it, opened it, and now it's already with air in situ. Despite that cornea being so hazy, I can see the F mark here. So here is the F mark, which I'm seeing well now, despite the cornea being so hazy. So future ideas could be 3D printed attachment device to the mobile so that your dependence on an assistant is reduced. And so coming to the next situation, DMEC with an unwelcome guest. So you can guess this is a case where the iris, the pupil was not small, old cataract PBK eye, and the capsule had fibrosed. So though there was no evident PCR to begin with, I'm trying to open. It's a half fold 40-60, usually opens well easily. But here, whatever I try, I know the graft is in the correct orientation, but when I put the bubble there, the graft got pushed. Something weird is happening here. So I have to remove that bubble and see my pupil became irregular. Meanwhile, my pupil became irregular. So you have that unwelcome guest there. Vitreous has come out. Always before injecting the graft, I'll put air and check if there is anything. There was nothing to begin with. But once I was inside with the graft, vitreous has started coming out. With the graft, you can't take an anterior vitrectomy. You may eat up the graft. So I have to resort to manual vitrectomy in this case. If it doesn't work, I may have to convert the case to a DSEC. But luckily, manual vitrectomy did suffice in this case. With spatula, finally, after a lot of manual vitrectomy, all the vitreous was cleared. Then I was able to center the graft. And again, now the maneuvers to open, flip, if it's origami, again open it, and then tap, tap, and try to open. But here, you know there is vitreous already. You don't want to shallow it too much, lest more vitreous starts coming out. So you have to be very gentle. And once you have reasonable opening of the graft, put a small air bubble under the graft so that you can use the air bubble to now help you. Now I'm keeping the air in the area of the vitreous so that vitreous doesn't come out again, and tap the other side open. Now you leave that air, go back with your cannula and expand the same air. Go merge it with the same air and expand it. Now your graft sits well. So that is about vitreous. Check it and suture your section. This is a case of vitrectomized eye, previously old vitrectomized eye with an anterior chamber IOL. So this case had a very deep anterior chamber with an AC IOL in situ. There was no reason to remove the AC IOL because that was, the PBK happened many, many years after the cataract surgery. So the AC IOL was actually well in position. So I decided we'll do a DMEC with a DSEC backup, and everything goes well. I get a nice double scroll here. But life starts becoming difficult after this. I'm injecting, shallowing the AC, injecting, but as I inject, you see, I want it to go inside. It's gone in a flush, and it's gone to the opposite end. The opposite angle, the graft is now stuck. And there is an AC IOL there. the haptic of the ACIL is there. So there is an irregularity in the anterior chamber and my graft is stuck there. How much ever I try to center or tap or do whatever, the graft is not getting released from that end. So the lesson is, how much ever you would not want to touch a DMEC graft, there are situations where you would probably have to touch the graft. I tried to release it with the spatula, tried to open it from the stromal side. Nothing did really work well. So finally, I had to shallow the AC and then take the help of a forceps. This is the situation where you will have to probably hold your graft in DMEC. Trying to unroll with all fluid maneuvers, it's not. Another thing is it's a vitrectomized eye. So in a vitrectomized eye, you usually have shallowing, concaving of the, so here I'm using a forceps, you see that? The graft which is stuck in the angle is now getting released. Finally, it's coming out into the center. There's a jerk with which it comes to the center. Now I'm okay. Now I'm trying to shallow, but it's previously vitrectomized. There is negative pressure, so your cornea is buckling inwards. The cornea is concaving. So that will not usually, the iris lens diaphragm won't come up to shallow. The cornea will go down in a vitrectomized eye. So with that, you will have to tap. You have to be careful. The ACIOL is there. You don't want the graft to lose cells with the ACIOL. So do a little bit of tapping, try to open. And again, like I said earlier, put an air bubble under the graft a little earlier on and then connect it. You will be able to open the graft. So that is my air bubble going in, a few fish egg forming there, but then finally my graft is open and I'm able to save the day with DMEC. So 6 months follow-up, the patient had, this was the cornea 6 months after the surgery in this ACIOL eye, maintained quite well. So take-home points, avoid compromise in visualization in DMEC. Vitreous needs to be identified and cleared as early as possible. A graft stuck at an angle needs release as priority. No touch may not always work. Vitrectomized eyes have negative pressure. Attempted AC shallowing buckles the cornea inwards rather than moving the iris lens diaphragm forward. A small air injection under the graft relatively early in vitrectomized eyes is helpful. And a stable, well-placed ACIOL is not a contraindication to DMEC. Thank you for your kind attention. Thank you.
Thank you, Seema, for the wonderful IC and
Thank you.
inviting us.
I thank my co-speakers, Dr. Bhaskar Srinivasan and Dr. Anita Venugopal. We'll have a quick photograph.